Hello and welcome to the Voice of the Patient podcast. We are the podcast working to change lives, that is, improve the quality of life through not only hearing, but truly listening to the voice of the patient.
Hello, everyone. Thank you for tuning in again to the Voice of the Patient podcast. I am your host, Zach Stearns, and my guest today is Dr. Andrew Rothschild. Dr. Rothschild has been practicing as a physical therapist since graduating with honors from Virginia Commonwealth University School of Allied Health in 2006. He is a Board Certified Orthopedic Specialist and is also a fellow in the American Academy of Orthopedic Manual Physical Therapy. He is one of the few residency and fellowship-trained physical therapists practicing in the Richmond, Virginia area. Dr. Rothschild, thank you for coming on to the show.
Oh, thank you so much for having me, Zach. I appreciate it.
Great. Well, to our listeners, I first found out about Dr. Rothschild through the Healthcare Disruption podcast with Jerry Durham. By the way, Dr. Rothschild, I love that podcast and I recommend it to our listeners. It covers a lot of great topics with a wide variety of guests. And then a few weeks ago, actually, I heard that Dr. Rothschild actually pursued the physical therapy profession after having an experience as a patient. And I had heard about that on the Nobody's podcast when Dr. Rothschild and other leaders in the profession gave their own commencement speeches to PT school graduates. So that was also a very awesome podcast episode, and I recommend that to our listeners as well. So I'll go ahead and get out of the way now. Could you, Dr. Rothschild, please tell your story as a patient?
Sure. So I graduated from college in 1999 with a degree in geography, which, as everybody knows, can transition smoothly into the realm of physical therapy. But I really had no plans or physical therapy wasn't even on my radar at the time. I thought I was going to be a teacher. I was going to go to grad school, but I was kind of sick of school after, finishing college. I wanted to take a year or two off and really go back when I was really felt that urge again. Mm-hmm. So, and I played soccer in college. I went to Mary Washington College. It's now the University of Mary Washington. But I played soccer for a couple of years there. Mostly sat the bench, but you know what I mean. And I had some intermittent back pain in high school and in college. It was very, very brief lasting, and it was looking back. I kind of have an idea of what it was, but at the time I didn't pay it any attention. Didn't go to a doctor. It was just I would feel stuck for like a week or so, where I couldn't bend forward. I felt like I literally could not bend forward. It wasn't really painful, but I felt stuck. But then it would go away, and then I would just ignore it, and it wouldn't come back again. It would come back, maybe every few months or something. Mm-hmm. Anyway, to make a long story short, I was working for a telecom company, just making a paycheck while I was thinking about what to do next. I tweaked it, doing some barbell deadlifts, and then I played some indoor soccer. And then after an indoor soccer game, I couldn't get out of bed one morning, and I had back pain, I had leg pain, going down my left leg, and it was at the time pretty miserable. I had to have my sister actually come over. Thankfully, she was home from college to help me get out of bed that day. Went to the doctor, basically gave me bed rest for a few days. Went back, had an MRI, and I was diagnosed with spondylolisthesis at L4-5. And I had a very classic spondylolisthesis, as you would learn about in PT school, where I had pain with extension. So I was hip extension, spine extension. I had shooting pain down my left leg. And my physician experience was fine as a patient. I had seen an orthopedist that was part of an ortho group in Northern Virginia that my parents and sister had gone to in the past. And he was he took a lot of time with you. My first PT experience was not very good. It was actually both my PT experiences as a patient were not very good. And that was sort of the driver ultimately for me when I would decide to pursue physical therapy as a profession. It wasn't because I had a good experience. It was because I had a not great experience, and I said, I can do better. Wow. So, and again, I had one visit of physical therapy for the first time, and they referred me to get orthotics made.
What kind of orthotics? Just for your
For my feet. That's what they determined after the initial eval was like the driver was my feet. Again, it's train of thought, whatever their exposure was. Maybe they had just gone to when the foot hits the ground course. I have no idea. Again, because I knew nothing at that time, right? I was 22 and didn't know anything. And I went and saw a guy who specialized in making custom orthotics, and $400 later, I had these rigid insoles that I wore, and it didn't make a darn bit of difference.
Yeah, sure.
And I never went back. They never asked me to come back. I never scheduled a follow-up appointment. They never had me come back. I didn't, so I just kind of left it as it was and went on from there.
That's amazing. Wow. I'm pretty shocked about that.
So I went a year and a half and just kind of did my own thing.
Yeah.
And my back pain actually seemed to get a little bit better, but my leg pain got worse, and I didn't know what that meant at the time. And I still had pain with sitting for a long time, standing for a long time. I couldn't run. Not that I was a big runner anyway, just couldn't do it. And so I went back to the doctor. I said, my back's feeling better. My leg's feeling worse. He was not as happy with that as I was. I started actually losing a little bit I didn't have really strength loss, but I was starting to get muscle atrophy actually in my glutes and my calf. And I ended up having be scheduled for a fusion. So I ended up having a fusion at L4-5 when I was 23.
Yeah, that's that. I just don't hear those stories from someone being 23 years old and get lumbar fusion. I can't say that I've heard another one other than yours at this point. Going back to say your experience with the PT, did you know at the time that this is not good? It should be better.
Yeah, probably more so looking back on later. I mean, at the time, I really, once the initial high-level irritation calmed down, those first few weeks of just more constant inflammatory type pain, once I was able to move more and do things, and then I could really do most things to a tolerable level. So I really wasn't that limited. Even going to the gym, I could still do most of the things. I just kind of, if I put myself in a position where I was getting that sensation, which was really that electric sensation shooting down the leg, I just didn't do that.
Right.
So that was kind of my life for a year. I could still walk. I could go out to the bars with my friends. I could go to work. I had some discomfort if I sat for more than an hour or so, or was in a car for more than an hour or so. And then I could still go to the gym and do most things. So it really wasn't always in the forefront of my mind. It was just kind of sitting there. And then that's what, I had some follow-up appointments with the doctor, and that's probably the only reason why I went back and said, well, if you're asking me how I'm feeling, I'm going to tell you what's going on. And that was actually, no, I forgot I did have 2 injections before the surgery.
Oh, okay.
I forgot about that part. And the first one seemed to reduce some of the symptoms a little bit. And then the second one really didn't add anything to it.
Right.
I'd forgotten about that. And I can't remember how soon they were. Again, we're going back 16 years now.
Yeah. Mm-hmm.
I can't remember how soon those were before the surgery, but that did actually help calm some stuff down at some point.
Okay. So you have the surgery. What's it like right after
that? So I was out of work for 6 weeks, and I moved back in with my parents just temporarily because I couldn't really take care of myself. I couldn't, you couldn't bend. I didn't get put in a brace, thankfully.
Right.
But I basically couldn't bend for 3 months. So it was just, and I'm very compliant with, physical activity and different things. And so I slept we put my mattress on my parents' pull-out couch in the living room, and I just kind of lived there for the first month.
Sure.
And I could take a shower and all that stuff. I just couldn't bend forward, and that was about it. My therapy was walking, so I'd go for a walk, a couple walks every day, and that was basically it.
Yeah. So after that, did you ever get a recurrence of back pain?
So I have had multiple recurrences.
Yeah. Okay.
I did go to physical therapy when I went back to work. Again, how did I find a physical therapist? I looked for somebody close to my office. So I could go during lunch. I went during my lunch hour, so I chose based on location. Again, my previous experience with physical therapy was not great, so I didn't know who was good or who to go to. And again, most of my life, even though I was very active from an athletic standpoint, I really didn't know anybody who went to physical therapy or anybody who talked about it.
Sure.
So I had no basis to kind of make a decision on. And so I just went to somebody who was close to me, and they were fine. And looking back, we just did a lot of basic stuff. I got heat for the first 20 minutes and I would fall asleep. And and they would wake me up and I'd say, "What? Now I have to do exercise? This is the dumbest thing ever. Why would you let me fall asleep and then wake up to do exercise?" It was organized very poorly looking back. And so then I would do a lot of basic stabilization exercises. And after a couple of weeks, I was like, I can do this on my own. I don't need to go pay money for it. Now again, this is back in 2004 when my copay was $10, which is you don't have those anymore.
Nope, you do not.
So it was nothing, and it wasn't like I was complaining about the money, but at the same time, I was like, it's still time and effort. I was like, I was a soccer player. I was a weightlifter. I can do these exercises at home. I don't need anybody to teach me how to do these things.
Right. So
I stopped going after a few weeks, and that was that. But yeah, like to go back to your question, I've had multiple recurrences. Mostly just back pain, localized back pain. I did really well for the first year and a half after surgery, and then I went downhill actually for a couple of years where I was really having more persistent aching symptoms, living on Advil kind of situation.
Mm-hmm, mm-hmm. Sure.
So, and then I did end up seeing a physiatrist actually at Georgetown University Hospital, which is where I had my surgery done. And that was kind of what got me. He did some hands-on techniques, which I really had never had before. And that's kind of what got me sort of jump-started over the hump a little bit. And then for the most part, it's just been me with what I've learned and what I know kind of figuring out along the way.
Okay. Well, so at some point, you decided you wanted to be a physical therapist too.
Yeah.
Walk me through that process of was it something about that therapist's office, or did you say, you know what, I like these hands-on techniques that I had just seen and want to actually be able to do some of that as a therapist?
It was really, I don't remember any specific like seminal moment that kind of the light bulb went off. It was just more the exposure to the profession, I think, that got me interested. And because I had a background in athletics and exercise, I liked, I originally thought I was going to be a teacher, and I saw physical therapy as a combination of the two, because you are essentially teaching or educating your patients, and you're working with them in a physical way. And it was like that little hybrid that it just kind of connected with me. And I said, I could do this. That's basically I had that sort of epiphany of this is something that I could do and I think I could be good at. And I kind of took it from there.
Absolutely. There's definitely so much education involved, and so many great clinicians will make a point about how education is maybe the most important thing we can do. One of certainly the most important things we can do as providers. So I love that background as being interested in being a teacher. And I think that's really, really relevant. Based on your experience with your providers and maybe any education that they provided, did you feel like they did a good job, or maybe could have been better?
Probably could have been better. I mean, I really don't remember any specific education in terms of, again, I don't remember anything that would have increased fear either. You mean we get a lot of that in terms of using words that can sometimes increase fear, words like instability and being afraid to bend. And I never had any of that, thankfully. But I don't remember having anything that was really, outstanding in the way of, something that would, again, I can't even remember it barely. I can't remember my physical therapist's name, but again, it's 15 years later, but I feel like I remember my surgeon's name though, so I feel like if it was a really profound thing, it's something that would have stuck pretty well.
So knowing what you know now about that whole experience for you, not just the surgery, but also, say, the experience with the orthotic, the experience with your therapist after surgery, what would you tell someone who finds themselves in that same situation that you are in?
Yeah, it's tough because, looking back, if I had had better therapy, would I have needed surgery? And I mean, you could argue that on both sides all day and never come to a conclusion. So I really don't know. And when people ask me if my surgery was successful, I say, yes, it was. Because I woke up the next morning and my symptoms that I went in for were resolved. I've never had that leg symptoms again since the surgery.
Right.
And it's taken a lot of work after the surgery. So I think ultimately surgery is just one piece. And I think a lot of patients assume surgery is just going to fix everything.
Right.
So I always talk about that piece of it. But I lean more, I definitely advocate strongly for the conservative approach as far as it can take it until it seems like that there is no other options. So when it comes to, and the research kind of supports this with spine surgery, is that, spine surgery just for pain does not seem to, the outcomes aren't super fantastic. The outcomes when it comes to true neurological compromise, so progressive neurological changes, loss of strength, loss of reflexes, loss of sensation, obviously anything within the lumbar spine, we're talking bowel bladder changes. When those situations are present, that's when surgery is very indicated. But just for pain, I really advocate more towards a conservative approach and so often maybe a multidisciplinary approach if necessary.
Sure. And at this point in my training, I'm still a student and going through clinical rotations right now and currently on my last one. I've seen so many patients who come into either the outpatient clinic or also in the inpatient rehab setting or even in the acute care setting who have had previous surgeries and talk about their surgeries almost, well, in some cases with definite regret because they continued to have pain. And part of that is maybe just the wrong expectations for surgery, to think that really if there's a lot less of an occurrence of pain, but still some pain here and there, then that doesn't mean that the surgery was a failure, right? But on top of that, I think that it speaks to the status of informed consent for a lot of treatments. So with physical therapy, it's really important to emphasize that there's no guarantee. We don't know for sure that this will help, but based on the odds, based on what we know with research, there's a greater likelihood that you would feel better with this. And this is just for a standard patient. And it seems like with a lot of patients who I've seen in clinic, that they didn't really get that same explanation about their surgery, that there was no guarantee, that they may still have pain later, that really we're just talking about odds of making pain less frequent. And this is excluding the situations in which there are progressive neurological symptoms, of course, in which surgery is absolutely necessary. But needless to say, I've actually found myself in some situations trying to defend surgery almost to patients, even though as a profession, we very often are more likely to defend conservative treatment than surgery. So in your experience as a clinician now, you are able to work with so many patients who have had surgery and maybe have that same sort of area of regret about it. And so what are some of the things that you tell your patients who are maybe fearful, either if they're after surgery or before surgery?
Yeah, I encounter some of the similar things that you do, in that patients are you have those patients who are regretting the surgery, but and this kind of is coincidental that I've just seen this fairly recently within the past week or two on Twitter. Is a couple published reports about alternatives and patients not getting alternatives when seeing a specialist about treatment options, and usually that surgery is the only treatment option that's provided for the patient. And so from the patient's perspective, unless you do the research, unless you're a good advocate for yourself, if you take which makes sense as well, if you're going to a doctor and they build trust, and you trust them, and then you may very well take their recommendation, and they recommend surgery, then a lot of people will go with that unquestionably. But if they're not given other options, so when other options are provided, that's the big difference maker. But a lot of times they're not, physical therapy or other conservative treatment isn't even mentioned as an alternative. Mm-hmm. So, when patients have had surgery already, I definitely not being in the room with them and the surgeon, it's hard to know what was said, right? Because patients will tell you what they took from it, or what their perception of the reality was, and the doctor may have given them that information, and they probably gave it to them in a written form as well, and it was not either paid attention to, or was not either retained, or was not read. So, like you said, it's about expectations sometimes, and whether it was said or not, the patient had their own interpretation of what their expectation was, and that can definitely have an impact on perceived outcome.
Sure, absolutely. Expectations are huge, and it's definitely for surgery. So, what were you leading into surgery? How were you feeling about it? Were you afraid? Did you think it'll be fine?
Not really. I mean, I wasn't afraid. I kind of went with it, and I really had no issues really going into it at all. It was just kind of very laid back about it, and it worked out well. My expectation was that I was confident in that it was going to be the thing that I needed. So that probably had a positive impact on my outcome as well, is that I had quote tried physical therapy, although not really, and and the surgeon was a very good surgeon, and from what I understood, he was the chief of spine surgery at Georgetown Hospital. And I was confident that if he said this is what was needed, then, that's what was needed. I mean, when he told me I needed surgery, I broke down and cried right at that moment. But later on, when it was time, I didn't have really any apprehension or anything.
Right. That was what needed to happen. This is what you're going to do. You're in good hands. And then it was going to be fine.
Yeah.
After the surgery, and leading up to today, you mentioned that you had tweaked it during deadlifts, or as far as activities that you do. Do you have any limitations now? Can you do deadlifts?
I do have some limitations now. I had done a bunch of barbell training a few years ago, and it got to the point where there was a load limit where my back was just not happy. I don't have an L4 spinous process. I'm sure I'm missing some multifidi back there as well, because it was again 16-year-old surgery. It wasn't a minimally invasive procedure as they're trying to do now. I actually broke the hardware. I have broken the titanium screws and bolts. I've broken within the first couple of years, but the bone fusion is solid. So I kind of, after a certain period of time of just dealing with a ache on a regular basis from deadlifts and squats, that's when I sort of discovered the kettlebell, and I've sort of adopted kettlebell training as my go-to modality, kettlebell and bodyweight training, and that really actually has really made a huge difference actually in my back health, I think, over the past few years, and sort of discovering that and learning that and becoming more proficient in it, that has really been a great thing for my back, actually, in a way, because you're not dealing with it's a lot more ballistic with the load, especially doing things like kettlebell swings compared to a deadlift. Mm-hmm. The imparted load can be quite high, but you're not having to lift the same amount of load. That from a strain standpoint. So that's been a huge discovery for me in my sort of rehab path here.
Awesome. And so I imagine that that's also something you're able to talk to a lot of your patients about who are in similar situations or with back pain.
Absolutely. And then the kettlebell is great because a lot of people, especially if there's fear involved with load, the kettlebell is a very unassuming load that you can start to use for patients for things like lifts and carries and different things, as opposed to, and for people especially who are not used to going to the gym, a barbell, for example, can be a whole lot more threatening. Like a kettlebell seems a little smaller, a little cuter, it's okay. Not as threatening.
You can go pick one off. You can go get one at the store and have it in your house.
But then once people do it and they realize, because I usually don't tell them how much things are weigh. They'll ask afterwards, like, "Oh, that was 35 pounds." Like, "Oh, really?" And that might be heavy to some people. And all of a sudden, that gives them confidence that, hey, look what I just did. So people usually underestimate what their capabilities are. And especially patients say, "Oh, I can't do that. I can't lift." What is the traditional thing a doctor tells a back pain patient not to do?
Don't lift.
Yeah. And what weight? Like 10 pounds, right? It's an arbitrary number. There's no data where that number came from. It says don't lift more than 10 pounds. Well, a gallon of milk is what, 8 pounds?
Yep.
So, I mean, people are lifting in reality more than 10 pounds all the time, but they have that number kind of in their minds, and that's a very fear-driving number. So all of a sudden you show them, hey, you just lifted 35 pounds off the floor with no problems. You're a whole lot more robust than you give yourself credit for.
Right. That's awesome. And it speaks a lot to how the role of confidence and feeling like that you can do that you can lift it without issues, can lead to a lot of better outcomes too. So I really love the kettlebell for that. I think that's a good tip, and it's a good encouragement to, maybe go get a couple more for myself too and have them there.
Absolutely.
Good tools. Yeah. And also with feeling like that people can lift, that they can do it well. It's consistent with a lot of the research out there too, that if people feel like they're doing a good job, if they can do it, that they actually end up performing better. And so I'm sure that you've seen that as well in your experience, that people end up performing better once they see that they can do it.
Oh yeah, I mean it's the power of belief, right? I mean you have that power of belief. It just plays such a immeasurable role. It's something that's hard to, you can't always quantify that, but that makes such a difference, I think, in people's ability to perform, and even just confidence, and in terms of fear reduction.
Sure. And I love the research that talks about clinical equipoise. So whether as a clinician, if you really believe in the intervention that you're providing, that can make a really massive difference. But if a clinician says, oh, this is what we do because, this is what you do, and I guess maybe it works, then there's not going to be as great of an outcome. So I'm sure that your patients really benefit from you being really passionate about about not only your interventions, but also just your confidence with conservative treatment. So, as far as also that aspect of clinical care, of really building trust with your patients, how have you worked on developing those skills as a clinician?
Confidence, I think, has come with combination of experience and training. And because going through a residency and fellowship, really getting deep into a lot of biomechanics, neurophysiology, rehab, a lot more confidence with my hands-on skills, that I think is translated into sort of the one-on-one relationship confidence, I guess. Because I used to be, when I was a young clinician, first 4+ years out of PT school, if patients weren't getting better, I didn't know if it was because of something I didn't know. Were they not getting better because of me, because I was not addressing something right, or didn't know, how to try to address the problem correctly. But after going through that process, I felt a whole lot more confident in my knowledge and my skills, and that, I think, translated into exuding more confidence with patients. And then again, like you brought up, kind of going through the process myself, and things I have patients do are all things that I've done. I never have patients do things that I've never done before. So whether it's any kind of mobility movement, or an exercise, or a strength training maneuver, I've pretty much done whatever I'm giving them, the patient. So I can speak to it from what it should feel like, how it should be done, what they might experience, where some limitations might be, how to regress it if necessary. So I think, again, having, again, air quotes here, kind of walked in their shoes to a certain degree, that builds a level of credibility too.
Sure.
And I used to not share my story so much with patients because I didn't want it to seem like I was making it about me. But I was talking to a colleague, several months ago, and they said, no, it's quite the opposite. Because once in a while it would come up, but I tend to bring it up now a little more often, especially with back pain patients, and that has really helped, I found, building trust quicker, building confidence quicker, because I've been through it as well, and so I'm an example of, hey, this is what can happen. You can get through this process with some time, some perseverance, and having the right person to kind of guide you along the path.
Right. Yeah, that's awesome. And I've seen some clinicians do similar things, maybe not necessarily for exactly that surgery, but other injuries or other types of pain to say, you know what, I actually had a similar experience. And then I usually patients will light up and be like, oh, really? And so it kind of, it humanizes the provider. To say, oh, wow, so these things can happen to you too, because sometimes patients might feel like the provider is, maybe doesn't go through the same type of pain and that they can't understand. But then on top of that, it also shows that, the provider's listening, is really thinking about what's going on with the patient too, and to say, oh yeah, you know what, this is just like, I had a similar thing. And, I've only really been able to do that with, say, ankle sprains, and I've this really bad ankle. I've sprained it a bunch of times, and I had this one patient who was college age, sprained her ankle, and she was like, "Oh, cool." I thought, well, cool. I don't know. I mean, I wouldn't go so far as to say this is cool, but hey, I have an idea of what's going on. So, yeah, I can imagine that that's been really a good tool when necessary, but I also really like your point that you don't want to make it about you, because they could go a wrong direction, because sometimes if someone goes through the vulnerability of going into an evaluation and they don't really want all the time to hear what's going on with you or what happened with you, they really want to share how they are feeling. So I think that's a really good point.
Yeah, absolutely. I think it's not, it's sort of, again, it's reading the room and figuring out the timing of when to bring things up. I've brought it up before at the initial eval. I've brought it up before 2 or 3 weeks into a treatment episode. So there's no rules in terms of when I do it or if I do it. I kind of just play it by ear and see when the situation might benefit from it. Only if it's going to add something in a positive way is it worth bringing up.
Sure. I think that's perfect. I completely agree. Awesome. Well, are there any other bits of advice, say, to other students out there who are in physical therapy and moving forward, or just to other clinicians about your experience as a patient?
Yeah, I mean, it's tough in terms of with students, especially or new grads. I think obviously the gaining skills as quickly as possible, I think, as a clinician is very important. And by skills, it doesn't have to be manual therapy skills, but in terms of clinical reasoning skills with communication, skills with marketing and sales, how to sell yourself, how to sell physical therapy, how to sell a plan of care, and then exercise skills, and then manual therapy skills are unbelievably important, I think. But because you use all of them all the time, and I think I heard on a podcast too, I can't remember which one I heard it on now, but it had to do with the fact that, especially the communication, the education, you do that with every single patient. I'm not always manipulating someone's cervical spine. I might do that a couple times a day, but I'm not doing that with every patient. But with every patient, I'm communicating with them, talking with them, expressing empathy, educating them. Those really might be the most important skills that we provide, kind of like you said at the top, Zach. And that's not something I realized until a few years ago. So that's what and I think it's, the manipulation, the dry needling, all that stuff is kind of the sexy stuff that people want to learn, because it's tangible and you can see it. But again, when you look at a if you're seeing 12 patients on Monday, what percentage of that day is spent doing those things? It's actually very small. It's the other stuff that's a little bit more of maybe a little bit more boring, for lack of a better word. But that really is the real, the real stuff that we do that can have a huge impact with patients. Is that piece of it.
Sure. That's great. And thank you so much for that bit of advice. I know that that speaks very well to me as a student and other students and new grads for that matter. So, how can our listeners contact you if they have any questions or comments?
I'm on Twitter at a Rothschild PT, ROTHSCHILD, and also on Instagram And you can find me on Facebook at Andrew Rothschild, and also Healthcare Disruption, co-host with Jerry Durham. You can find me on our Facebook page there as well.
Perfect. Awesome. Dr. Rothschild, thank you again so much for coming on to the show.
Absolutely. Thank you, Zach.
Sure. Well, that concludes our episode. If you enjoyed this episode, or if you have a story to tell as a patient, a provider, or both, then let us know. Find me on Twitter at Zach R. Stearns, or you can find Dave Reed at DReedPT. Thank you for listening, and keep listening to the voice of the patient.
If you enjoyed this episode, go to thevoiceofthepatient.org, where you can find other helpful podcasts and blog posts that will show you how to improve healthcare through not only hearing, but truly listening to the voice of the patient. Thanks for listening. This podcast is brought to you in partnership with the Senior Rehab Project at seniorrehabproject.com.